In the last segment, I began by describing some early experiences I had had as a therapist in that dark time known as the 1980s. And I described what felt like sort of remarkable improvements very ill people made, of course, the course of that psychotherapy. And I left impressed that psychotherapy offered something, but I was unsure what it helped people to do. I was unsure what the processes were. And in response to that, I have presented you now a considerable amount of information about a potential way to measure and operationalize metacognition. And my hope is that I've described something that could describe some of the changes and problems that people had, the very people I met with in the 1980s in this small clinic as a student. And I want to now move and talk a little bit about how psychotherapy could play a role in helping people to recoup this capacity. And I want to talk about the basic parameters. I'm going to offer you some case illustrations of change, and finally talk about some qualitative and quantitative research. I want to, though, discuss this issue of psychotherapy in light of some of the core fundamental ethical principles that, as psychologists, we embrace. And you'll forgive me for reading, but I'm going to look at essentially principles A and E, and I'll tell you a little bit about what those are. We'll move forward to talk about psychotherapy, and then ultimately talk about how this work may fully satisfy these principles. Principle A, as you probably know, is the principle of beneficence and maleficence. And it says psychologists strive to benefit those with whom they work and take care to do no harm. In their professional actions, psychologists seek to safeguard the welfare and rights of those with whom they interact professionally and other affected persons. Principle E, respect for people's rights and dignity. Psychologists respect the dignity and worth of all people and the rights of individuals to privacy, confidentiality, and self-determination. Psychologists try to eliminate the effect on their work of biases based on factors such as the personal factors of individuals. I've chosen these two because at the core of recovery from any form of severe mental illness, including schizophrenia, is that a person has to take charge of their own life. And there is always the likelihood that interventions, no matter how benevolent, do not empower the patient, but offer them advice or direction. Ultimately, therefore, curbing chances for recovery. And I also offer these as particularly important because of stigma. And stigma refers, of course, to widely spread societal beliefs that people with severe mental illness are things such as dangerous or incompetent or not to be trusted. And those beliefs, the stigma, are everywhere. They're in comedy, they're in movies, they're in all of us. And there is a need to safeguard against that, again, if we're going to help people achieve wellness. So I'm going to now talk more about what psychotherapy could look like, but then I hope to return to these core ethical principles and talk about how a metacognitive approach to therapy might satisfy these in many important ways. So let's go to the form of a question. If metacognitive deficits are a root of dysfunction, could psychotherapy be a place where people develop the capacities for self-reflection, for awareness of others, for decentration, for mastery? So, in the first really large portion of this talk, we've discussed how these deficits in metacognition are prevalent in schizophrenia and are related to function. But could psychotherapy then address this? Could psychotherapy assist persons to form more complex ideas of who they are, who other people are, to see the larger world, and ultimately to make decisions about how to have a life that's as healthy and sensible as possible? In beginning to think about this, I'm going to suggest first that we're talking about a psychotherapy that's integrative in nature. We're not talking about a new acronym We're not talking about a new, highly specialized practice that exists discreetly and separately from everything else. We're talking about a practice in which a range of styles, of techniques can be brought together all through a strong theoretical bond or basis. The second thing I want to bring your attention to is that this is a process in which interventions are keyed to help people think about themselves and others by intervening at the level at which they are capable. So if you think back to our discussion of the different levels of self-reflectivity, at the fourth level, we think about people who are able or not able to recognize their own emotions. If you are treating someone who is unable to recognize their own emotions, asking them persistently about how they feel is likely to be useless or frustrating. If you think about the fifth level, which is knowing that one's thoughts are fallible, people who are unable to doubt their thoughts, continuously urging people to doubt their thoughts when that's not something they're capable of seems like it could again be frivolous, if not, in fact, destructive. In some of our own unpublished analyses of our casework, our finding is that oftentimes patients will produce substantial amounts of psychotic material in session when the therapist has asked them to create an idea that's too complex, that's beyond their ability for integration. And again, I want to say that we're not suggesting that some patients are more reflective than others or that some patients are not reflective. What we want to suggest is that patients differ in their capacity to integrate information. Everyone we see is reflective. But at issue is are the bits and pieces of that, can they be brought together into the moment and spread across time? So this integrative therapy is one that would target a capacity. It would look to help people become more able to do something. It's not a therapy that's interested in a specific content or solving a particular problem. Certainly, we hope that as a consequence, people will figure out by themselves or with us how to solve a range of problems. But the goal of metacognitive therapy, or a therapy that targets metacognition, is that persons would become better able to integrate information, not just avoid one problem after another. And this may involve helping people practice and learn to perform increasingly complex activities. Probably, if you call to mind the image of the therapist in your favorite movie, the therapist is a warm, perhaps even cuddly person who's very thoughtful and very perhaps pensive or funny or has some sort of great wisdom. And that's not an image that's helpful here for me. In fact, I think that sort of gets in the way. The image of the therapist I would want you to conjure up is someone who's perhaps a physical therapist, who helps someone to practice something that's painful again and again and again and again until they get better at it. Not as romantic an image as the warm, cuddly therapist from, again, pick your favorite movie. And then we would expect improvement in metacognition, or the ability to bring information together, as occurring along a continuum. In other words, it isn't something you just get, but that you get better at it slowly and over time. This is also activity that would occur when you talk with people about their lives and who they are and what's happening around them. So, lots of stuff goes on in usual, quote, talk therapy. In fact, sometimes it seems that as long as you're doing something and not prescribing a drug, it's called talk therapy. People are solving problems, they're interpreting, resolving conflicts, they have helpful skills to share, they're telling people they shouldn't believe strange things. There's education, there's the teaching of life skills, there's befriending, there's advocating, there's promoting hope. Lots of activities go on. We're not trying to add another activity to that list. The metacognitive therapy that I'm interested in describing to you is one that may or may not do these things. What it will do first and foremost always is try to promote the ability to bring information together and integrate it into a complex sense of who a person is. time, I guess, for round 2 of So What? It sounds good, but could you really do that? I'm going to talk about 2 early case studies that we published quite a while ago, which tried to ask the question, if you look at someone talking about their life within a long-term psychotherapy case, does the complexity of their metacognitive actions change? In other words, do they create more complex ideas of themselves or others? So the first case is a case that we published back in 2005. This is the case of Grieg. As you would imagine, Grieg is not this man's name, and everything about him that I'm going to tell you is disguised. Grieg was a man in his 40s who had a number of prominent delusions, had a number of profoundly irrational and odd beliefs. He had very few social contacts. He had had a life of multiple hospitalizations. He lived in a nursing home. He took multiple doses. He took multiple medications at relatively high doses and hadn't worked in years. He had very poor neurocognition. And if you think about any of the typical markers for success in psychotherapy, Grieg had none of them. So long ago, we talked about the Yabis client. Young, intelligent, whatever the rest of those things are. Grieg was none of them. In fact, Grieg only came to enter psychotherapy because he'd had a terrible fight with his nurse, and more or less they were both angry with each other, and so a new therapist was assigned, who was me. I then went on to see Grieg for a period of 2.5 years. We met every week, first for 30 minutes, which was all I could tolerate, then for an hour. And all therapy sessions were taped and transcribed. I'll tell you a little bit about Grieg as a person. He had multiple losses in relationships. That was something we came to talk about a lot. He himself decided that he was unable to love, that his core psychological problem was that he couldn't form any sort of affectionate connection to another person. He talked to himself disparagingly, thinking that he had no social rank or no cause for anyone to take him seriously or appreciate him. And he wasn't even sure if he had schizophrenia. He wasn't sure what was wrong. He didn't like taking medicines. He took a boatload, but he was terrified of stopping them for fear of what would happen. Initially, in this work, it was difficult to sit with Grieg. It was hard to know what he meant, what he wanted from me, what he was asking. I frequently felt confused. I frequently felt like I didn't know what I was doing, that I had no social rank. I frequently thought that this was a sham, that maybe I wasn't really helping him. But as I had in this small town in Ohio many years earlier, I kept at it. So our method for answering the question, did Grieg's metacognition improve over time, was to take his transcripts, to de-identify them, and with institutional approval, to have a blind rater rate metacognition in each transcript without knowing the order. In other words, with no knowledge of whether this was the first session or the last session. We'll show you a graph in a moment, which is what we found, and here it is. What you see is that Grieg, over time, starts with very low levels of metacognition. Along the bottom, you see the number of months in therapy. Again, this is 2.5 years. Along the top, the total score for the Mass A. And you'll see a line surrounded by 2 other lines. The 2 other lines are a 95% confidence interval, fit around essentially a nonlinear line, showing significant growth over time in metacognitive capacity. So yes, Grieg's metacognition did improve over time. He began with almost no sense of himself or others and ended with richer accounts of himself and others. Also striking in this graph is that the variance around the bands is gigantic at first. In other words, Grieg shows rapid spikes followed by rapid declines, jumping up and then falling back to nothing. And again, as you can see here around the 16th month, Grieg hits a low that's very close to where he started. So he's been moving up, moving up, moving up, and then plummet. This is certainly a session. where I must have been convinced that I hadn't helped him and was a failure and was not succeeding in doing very much for him in any way, in spite of my ideas and hopes and dreams that this could work. But it goes up again, and then it stays up, especially towards the end. Grieg makes a number of remarkable changes over these 2.5 years. His symptoms are significantly decreased. And I think above and beyond anything else, so he comes to think of himself as a human being whose life makes some sense and which can be navigated in some way. As you may have recollected, this is a scale, the MASS, Metacognition Assessment Scale, originally developed by our close colleagues and friends in Italy, including Giancarlo DiMaggio. And hence, in our second case, at their insistence, we used a second classical composer, Scarlatti. There were no threats involved coming from our Italian colleagues, but we wanted to make sure. So Grieg, of course, homage to the great Norwegian composer, and Scarlatti, homage to the great Italian composer. Our second case named Scarlatti. Again, all the details are changed. Scarlatti was also a client, patient, who met no Yavas characteristics. He had a long and potent substance abuse history. He had a number of very unusual and strange beliefs. He was also a difficult and angry man, and quite unpleasant to interact with. In fact, he had been fired by many therapists for cussing at them and saying rude and inappropriate sexual things to them. Again, a symptomatic man, poor neurocognition, many characteristics that would speak against psychotherapy should ever help him. In fact, probably in many clinics throughout the world, the prescription would be some sort of skills training. In the case of Scarlatti, actually, and in Grieg, they had both tried any number of different skills trainings with no effects. So as in the case of Grieg, Scarlatti and I met every week. We met in my office. We met for an hour. Early on, the sessions were full of a lot of strange and odd beliefs, a lot of angry remarks about me, many comments about my inadequacies and failures as a person. And slowly, though, then there began to be some talking about his life. In both Grieg's case and in Scarlatti's, the patient would sit down and begin to tell me about their life and what was going on in it at the moment, going back and forth between what they remembered about themselves and what they were facing. There was a focus on an intense need for approval that Scarlatti realized he had. He began, as did Grieg, to not believe some of the odd things anymore. In other words, delusions went down. Except for Scarlatti was really direct about this. As he believed these things less and less, he felt less and less important as a person, and his life felt as if it had less meaning. So there was not only his pain, but the pain that was caused by some of his own moves towards wellness and health. Talked a lot about his anger and conflicts with different people he was involved with on a daily basis. Our methodology for Scarlatti was the same. We looked at transcripts across 32 months. Actually, for Grieg, we looked at 2 per month. For Scarlatti, 1 per month. Again, the transcripts were blind to the date it took place. And we had institutional approval for the exploration of these transcripts. And as you'll see here, we fit both metacognition, the total score, and a rating of delusions on a 0 to 100 scale. On the bottom is the observation number or the month. And here higher scores mean more. So you'll see that the dotted line, which are delusions, starts off relatively high and then drops. The solid line, which is metacognition, starts out relatively low and climbs. And I'm sure that you are struck at, again, a sort of sine wave that we see in these graphs in which gains are followed by losses, gains are followed by losses, gains are followed by losses, with a general trend going upwards. As I reflect back on this work and other work, it seems as if a common occurrence is as people become more aware, as the pieces are fit together, there's pain. And with pain there comes then regression. And so it's the old story of 3 steps forward, 2 back. In the second image, we looked at the actual subscales of the Mass A. In other words, what tended to improve first and what came only later. And what you'll see here is the hard line, which is self-reflectivity, was really the first to improve. In other words, across these 32 months, Scarlatti began to develop a richer sense of himself, a more coherent, integrative sense. That was followed by gains in mastery, and strikingly, awareness of the other begins very poor and stays poor for quite a while. In fact, it isn't until observation point 17 in which there's any growth at all in the idea that others have feelings or emotions. So I hope from these two graphs I've been able to show you some evidence that this phenomenon of metacognition could change in psychotherapy. And again, we've purposely selected two persons who had profound deficits and seemed by conventional wisdom to be the least likely to benefit, and yet both profoundly did. The last thing I'm going to present to you in terms of the evidence supporting this as a potential possibility comes from a series of qualitative interviews that we've just finished conducting, and that's currently in press. In particular, we took 12 patients who had been receiving metacognitively oriented therapy for at least a year and performed a qualitative interview asking patients about, when you see your therapist, what happens? What goes on when the door closes? What are you able to do because of this that you couldn't do before? What is it like when you leave? What do you see in the future in terms of your meetings with this person? Just a general but focused description on what's going on when you meet and what's happening in you. For comparisons, we found 13 people, also with severe and persistent mental illness, who were receiving standard supportive therapy but no supervision in metacognitive-oriented therapy. Again, we asked questions such as, is therapy helpful and how? What happens when you meet with your therapist? How do you know if it's helpful? What's changed? Do you think about your life differently? Et cetera, et cetera. We then coded all of those interviews, blind to whether the person received supportive or metacognitively oriented therapy, and came up with a number of codes. So across all of these interviews, people talked about agency or the ability to discern the causes of events in their life, self-stigma or rejecting stigma. They talked about self-esteem. There were also themes for narrative coherence or comments about how the present is coherently linked to the past, which then moves into the future. There were codes given for the regulation of painful affect, for reduction in painful affect separately, clarity of thought, and life goals. And in terms of what we found, everyone said they liked psychotherapy. And of course, we were only sampling people who'd been in psychotherapy, many of whom had done it for years. So naturally, they liked it. If they didn't like it, they would have stopped. And all said that therapy helped them to think clearly, they felt more confident, they felt less stigma, and they felt like they could set goals for themselves. The differences, though, that emerged were these. People who received the supportive therapy noted unique changes. They uniquely said that they felt less pain when they left the session. In other words, as a result of seeing my therapist, I walked away in a better mood. I felt a little better. People in metacognitive therapy did not say that. They did not say that they felt better at the end of every session. What they said is they felt better able to regulate and manage pain. They felt better able to tolerate being upset and facing frustration. They also felt that they had a better sense of being able to direct their life. How do you know if therapy helps? I'm able to direct my own life now. I make my own decisions. And lastly, they talked quite a bit about narrative coherence. The goals they were setting, the dilemmas they were facing in the present were all discussed in the context of their life and their own personal history. So I think you see some unique benefits to this metacognitive approach. In the supportive case, people see a therapist. That therapist is warm, friendly, perhaps gives good advice. They feel better. They like the guy or the woman, and they leave. And they're sort of back there next week, perhaps feeling better, but usually back to get the same boost of their mood. The other group finds this to be a difficult therapy, but they feel they can manage pain, that pain does not destroy their lives. that they are an agent in their lives, and that the present is somehow part of a larger web of events called their life. So this segment began talking about, could therapy possibly help metacognition? And I hope I've presented a small amount of information suggesting that at least in 2 case studies, we find metacognitive capacity increased. And in one qualitative study, we also found people receiving this therapy talked about it as helping them in ways that are consonant with the theory. The next step is going to be to talk about how to operationalize the elements of the therapy. It could be the case that much of psychotherapy has been plagued either by interventions that are so vague that it's hard to tell what they're composed of, or interventions that are so scripted that they feel more like a telemarketing interview or an activity that would take place in a factory, rather than a complex interaction between 2 human beings discussing difficult events. So our group, partnering with a number of others overseas, including Giancarlo DiMaggio, Suzanne Harder in Copenhagen, Elanit Hassanohayan in Israel, and others, set about, others include Andrew Gumley in Scotland, we set about to create a list of core processes that should be present in a session. In other words, we hope to describe the principal elements so that this sort of therapy would be observable and practicable, but again, not reduced to a set of activities done in a particular order, again, robbing them of spontaneity and a chance for creativity. We also set about trying to come up with a set of values that would be applicable to a range of different approaches. So, could we describe processes which could be used by humanist, an existentialist, cognitive behavior therapist, a psychodynamic therapist, a gestalt therapist, any number of legitimate, reasonable orientations. So, at the heart of all of this, our goal again was not a new acronym, not a new thing to do that's unlike other things. But with core training, could you learn a set of skills that would help you to creatively address metacognition and assist people with schizophrenia to move towards wellness? Thanks to our friends in the Netherlands, we came up with a title called Metacognitive Reflection Insight Therapy, MERIT. So in some ways you may say, aha, you've gone ahead and given us an acronym, and I have, but I hope it is an acronym which is integrative in nature and that is, again, useful to people from across perspectives and offers the opportunity for creativity and the use of your own intelligence. I now want to describe to you what this merit is and then ultimately talk a little bit about its application. Merit begins with a set of core values or principles. And the thought is that these are things that if you don't embrace, it's not likely that this is going to work very well. So a dear friend of mine, Reed Cleon, often refers to this as the preaching part of the lecture. I will endeavor to not preach, but inevitably I'm sharing with you that there are some ideas that if you don't entirely buy into them, I'm not sure how this works, or I'm not sure if you're really going to help people with these procedures. So the first of these values is that recovery from severe mental illness is possible, and that in fact most people achieve some meaningful degree of recovery. The second core value is that patients are active agents in their own recovery in all phases. And here the idea is that even the most ill people can be spoken to, or even the most ill people are trying to make some sense of what's happening, and they may not be doing it efficiently or effectively, but we need to regard them as doing that, as active agents in their life. I might say, take the moment and note that I use the word patient and have throughout. Patient is often rejected as a term for people receiving psychotherapy. It's been rejected for a term. It's been rejected as a term for psychiatric rehabilitation and for consumer or client. I use the word patient because of its roots and its meaning being one who suffers. So first two core values, recovery is possible, and that patients are active agents. The third is that the role of the therapist is as a consultant and an equal partner in the process. Not one who is prescriptive, has a bunch of clever answers to dole out when the time is right, or is a more powerful other. We talked earlier on about the intersubjective nature of metacognition, that we don't decide who we are, we decide with people. And if there is not a movement within a session in which I am thinking with someone about them, not at them or down to them, meaning making is unlikely to occur. The next value is that the experiences of persons with psychosis can be understood by those persons and by others. In other words, human speech acts against even the most ill people, human speech acts, even by the most ill people, have meaning, and that meaning can be understood. The paranoid delusion may express terror. There's something there. I feel terrified. The most grandiose belief can express, I feel small, or I need you to see that I'm important. The next value, and this is hinted at by one of the findings I shared with you earlier, is that with greater levels of awareness, people may experience distress. In other words, having a deeper sense of who you are and who other people are does not result in the proverbial party with donkey rides and balloons from the sky. That it may be that coming to know who you are and who other people are, you encounter things which are painful and disturbing to you. And last is that stigma is found in all corners, as I mentioned earlier, of the world, and has a profoundly negative impact on the lives of persons with mental disorders. If I have a mental disorder and I'm seeking to recover, and yet I believe I'm incompetent and dangerous, it's going to be impossible for me. And stigma needs to be rooted out as we talk. So we propose these as core values, as things that therapists need to have some sense of. Perhaps the word buy-in is appropriate here. But so what do you do? What happens in session when the door closes? What is merit? What are those elements? What I'm going to do next is to talk through each of the 8 elements. So this group I described, we on our own, without funding, came up with these 8 elements. And this is a series of intense emails, probably over a course of about a year, followed by rather intensive study of therapy transcripts to see the extent to which we think these elements could be observable or not within a therapy session. So for the 8 elements, it's important for me to say these elements are not sequential. These elements are not one thing to do right after another. They're not a lesson plan. They're not a curriculum. They also are closely related to each other and likely amplify one another. And each element describes a component practice that occurs within a session. And our hope is that each of these elements should occur in every session. It should happen the first time, the middle however many times, and the last time you meet with someone. And theoretically, these 8 elements should assist people to develop metacognitive capacity in the way that we observed that Grieg and Scarlatti developed this metacognitive capacity. The 8 elements are not a substitute, though, for therapist reflection. They don't get you off the hook for having to think and know. And they do not guard you against confusion or feelings of inadequacy. In fact, if you sit with someone who has a profound psychotic disorder and you don't feel in some way inadequate or confused, you're probably not really present, or you're probably fooling yourself. So they don't think for you, and they don't shield you from how difficult this work can be. And lastly, these 8 integrative elements are not only measurable, but they're also connected to each other through a model. And if we go back to these ideas that I've talked about earlier with metacognition as a core dysfunction, which then leads to an interruption of a life. These are 8 elements that could conceivably address or treat this. And I'm going to take just a moment to emphasize this idea of treatment. Again, all sorts of interventions which don't involve agents are generally called treatments. But here we're talking about something that I think is a treatment in the sense that it's going to address a core cause of dysfunction. We're not talking about something that's going to be supportive while someone takes medicine that hopefully works. We're not going to hold someone's hand while they go through difficult times. We certainly may be supportive. We may compassionately relate. But the idea here is that a core dysfunction, this sort of lack of glue that keeps integrated senses of self and others together, that's fallen apart, and we're going to address that. And that people may come out of this treatment better able to do these things. Again, it may actually treat something that's core to the disorder. I've already said this, but the hope is that any of you watching this, you already have some idea of how you want to practice and what good practice looks like. The goal of this is to stimulate your practice and to help you to find creative ways to help people who previously, perhaps their dilemmas were mysterious and beyond your help. So the first of the 8 elements is the agenda. The goal of this first item is that people will become aware of their wishes and intentions. So what we mean by agenda is the following: that a person comes to session with a mission. They have a wish, a hope, a goal, who knows what, but they have one. And that at some point in your session, perhaps sooner than later, you're going to wonder about what that goal is and what the mission is. What are they there to get? And here it is not assumed that this is a simple answerable question. The idea here isn't merely that I say to the patient, what is your goal? What are you hoping to accomplish today? You might say that, but you might not know, particularly if you have a severe psychotic disorder. Or you may have lots of things you want that are utterly contradictory. Or you might want one thing and that thing might change. Or you might want things that I don't want to do as the therapist. A patient may well come in with the goal of that I will side with him against his wife who he's angry at. Or a patient may well come in with the goal of my telling him that it's okay that he never works again. Or that it's all right that he used drugs. Or that it's okay that she didn't pay her child support. The agenda may be to keep me at a distance so I don't realize something that's painful or embarrassing. The agenda could be that I should become dysregulated or upset or afraid. The agenda could be that I should understand how frightened that person is or how terrified they are of leaving their house. It may be a rich goal, it may be an impoverished goal, but human beings do things for reasons. A patient may say, my agenda is to come here and see what happens. Puts you in a tough spot as the therapist, doesn't it? But that is a legitimate agenda. Again, you can talk about that, whether you want that to be whether that should be their agenda forever. But with this first item of merit, the wish is that you will help someone see themselves as having intentions or goals. You'll help them know their own mind in the moment that they've come here with a purpose. And whether that purpose is met or not is irrelevant. What's more relevant is that they realize their purpose in the moment and what they're seeking. So how do you do this? How do you ever determine what someone's agenda is? Certainly, if there was an easy way to do this, the field of dating would be relatively simple. We would all have books for how to tell the potential wishes and goals of people we're interested in, and then the many disasters which are the world of dating would never occur. So let's just take that as evidence that there is no way to know for certain what people want. But yet we don't give up, and basic relationships are built on mutual understanding. So there's necessarily an ongoing and evolving understanding of what people want as you interact with them. Part of it's intuition, part of it is direct inquiry. And probably we know something about what messes it up. In other words, what are the barriers to getting to know the goal? And those include taking at face value what people tell us their goals are. So if you'll allow the dating metaphor, person A says to person B, my goal is to get to know you as a person. And they might have an ulterior, or they might have a different goal in mind. And you would be rudely surprised that they were interested in something else other than getting to know you, unless you read more deeply into what it is they're asking. So taking verbalizations at face value is not a way to figure out what someone wants. And certainly in your own life, I'm sure you can remember any number of times when you've told people what your goals were just to get them off your back, when you had other things. But also ignoring subtleties and hints is another way to sort of miss what it is. Or taking things as useless. If a patient comes in and sits down and says, gee, it's warm in here, perhaps it's merely a request to turn down the thermometer, or it's a comment about having anxiety about something. Regardless, the agenda involves attending to the patient's immediate wishes and desires, and this is a difficult and ongoing process that should be present in every session. Requires the therapist is continuously attuned to what the person is seeking and thinking about it with them, not just waiting for the patient to reveal it. Again, I'll tell you that these agendas are varied. It can be to feel less anxious, to establish something is not one's fault, to make the therapist feel confused, to convince the therapist to agree with their estimation of someone else, to feel safe, to feel connected to someone, to be rejected. Perhaps the goal is to anger the therapist so the therapist will push them away. To be admired by the therapist, to please the therapist, to seek permission to give up, to avoid a drug relapse, to march into one happily, to decide how to respond to a loss. Bottom line for item 1 is there should be evidence within every therapy session of thinking with the person about what they're looking for. And this is a success not because you find or don't find the agenda, but because you think about the agentic quality of the patient and that person thinks about themselves as having a potential agenda. The second issue is the second element we refer to as dialogue. And the goal of this is that patients will develop a greater awareness of how they are reacting to the therapist. In other words, with the first element, the person becomes more aware that they have wishes and desires and what those wishes and desires are. And with the second element, they realize that you, as the therapist, are perceiving that and that they are reacting to your perception. And this requires that the therapist share their thoughts about the patient in a way in which there's mutual reflection and that does not disrupt the dialogue. What thwarts this? Well, taking a hierarchical stance, deciding you're an educator, playing the role of sort of a clever elder who has some tricks that the person can use to escape whatever dilemma is happening in the moment. It can also be thwarted by being scared or timid. If you're worried you're going to upset the person, if you feel paralyzed by your own anxiety, then your mind doesn't enter in. If you're frightened of making a mistake, you're destined to hesitate and miss an opportunity. This is not permission to be reckless, but you don't get... Dialogue doesn't happen because one partner sits quietly and, again, fearfully in the distance. So the dialogue involves sharing the therapist's thoughts about patients' mental activities and behaviors, again, not overriding or hijacking patient agendas. Patients are offered the chance to think and reflect about what they think about the therapist's presence. This can be as simple as, it's hard to sit with me today. You seem to like seeing me today. This isn't going well, is it, for you today? Sharing one's own thoughts sometimes is as hard as understanding the thoughts of the person sitting in front of you. But it can involve things like saying that I feel if I say the wrong thing, I'll anger you, to the patient. You haven't spoken about this crisis that we talked about last time. Is that something we should bring up? I can't decide. Do you wish I hadn't mentioned the crisis? Do you wish you could erase the crisis from my mind? I'm glad you're here today, but you haven't come in for quite a while, and you haven't mentioned the missed sessions. Should I skip that over? Or I'm thinking about that, and I don't know if I should bring it up. I might say, you seem to be smiling, but you're describing something very painful. I'm feeling confusion in my mind. Or, I'm confused by what you're saying. I don't know what you mean. I notice you're wearing dark glasses. Or you're saying things that I think I should be anxious and nervous about. In all of these snippets I've just shared, I hope what comes across is my interest in sharing my thought with the patient, but allowing them to tell me what it was like for my knowing them. So they now have the awareness of being known as well as an awareness of their wishes for the first two. Biggest ways that this gets messed up, in our experience, is feeling anxious and not talking, or quickly wanting to soothe the patient rather than know what it is they're really saying. Excessive politeness or timidity again are a problem, or also getting sort of stuck with your own agenda. Perhaps you're angry that the person hasn't come to see you in 2 times, and that's not how you think it should be, and you'd like to give it to them. There's no precise list of ways to mess up this second element, to derail dialogue. But our group has come up with 4 general sort of caricatures or positions that therapists often find themselves forced into that might be worth thinking about for just a moment. These are positions that I think are probably commonly found and get in the way of an open dialogue with a patient about their experiences. The first of these positions we refer to as the arbiter of reality. And here we have in mind the position where I, as the therapist, decide, I know what's real. These delusional things are not real. I need to help you see that they're not real and to think without it. So, of course we don't want people to hold false beliefs or delusions. But if my position is that I know what's real and you don't, I don't know how I insert my own mind in our conversation without derailing things. A second and trickier stance that I think we often all feel pulled into is to be an ambassador of health. And by the ambassador of health, we mean the therapist who feels like they should take this knowledge about health from this healthy place where there's the healthy us and go to the unhealthy place, which is where the patient is, and give them this health. And it could be that this is this beautiful thing that I practice in my own life that helps me. I think you should do it too. I won't pick on any number of healthy practices, but you can insert your own favorite one. In my life, I practice X. I think if you practice X, it could help you. So, I'm an ambassador in that sense, bringing health to a person. It's hierarchical, it doesn't promote reflection. It may give someone good advice. The third of these problematic stances we refer to as the minister of comfort. And here we want to describe a position where I also think we're pushed into that we're supposed to comfort people. That these are people who suffer. And indeed, people with schizophrenia suffer. But if my primary position is to in essence, give a proverbial cup of hot tea or a warm blanket, it's not the same thing as this are the thoughts in my mind and what's it like for you to encounter them. Last person Our last position we have thought about is something we call the spokesperson. And this is in essence the hardcore advocate for the patient. So, in all of these things, of course, we don't want people to think we don't want people to hang on to unreal beliefs. Of course, we want people to do healthy things. Of course, we want people to be comforted. And of course, we want to advocate. But each of these positions somehow blocks a kind of pure knowing between two people that can ultimately promote a person making their own sense of the world, bringing their own ideas together. And these are hard things to reject because it makes us sound cold or callous. The third element is a narrative focus. In other words, we are interested in stories. As human beings, we are storied beings. We narratize everything. When we meet new people, we don't sit down and tell them our core beliefs or our principal values, or if we do, it's sort of strange. We tell people stories about our lives, where we came from, where we went to school, boyfriends, girlfriends, what we dream about, what we used to dream about. And we're interested, therefore, in merit. When people want to talk about their lives, we want to hear about stories, not just abstractions. I want to hear about a time when it happened. If the patient says something like the following: I've decided I reach false conclusions and don't trust people, and I've got to stop that. We want to know, tell us a time when that happened. We want to know a place, a group of people, the events, and let's think together about it. Again, the goal here is not to fix a problem, but to help someone think about themselves as a being in the world who is involved and intricately involved in events in the world, and is not separable from them ultimately. The therapist, therefore, has to elicit and explore narrative events. Sometimes this is deeply difficult for patients with schizophrenia. I described these patients early in my experiences in Ohio as having almost no story. And it was very painful and difficult to pull up anything. There were fragments, bits and pieces, again, a kind of fog. But I don't fail at this element if I don't get the complete story. In fact, the goal is not to get the complete story. The goal is to think about the person in a storied way, in whatever way is possible. A person may merely list they lived at 5 addresses over the course of their life, but not knowing in what order. Major impediment to this probably is mistaking abstraction for knowledge. Patient says, my parents got divorced, that was terrible. You say, yeah. But no, you don't know what it's like unless you know the details, unless you know the stories, unless you know the people involved. So the goal here is to forge a mutual understanding with patients by viewing their experience as comprehensible, comprehensible, and available for understanding. Patients are expected to vary in their abilities to produce coherent narratives. Some will begin by producing only fragments. Sometimes the best narratives to begin with are the least painful, the easiest to recollect, to think about. And discussing a narrative is not a matter of always finding a new story. It may be that in any of our relationships, we retell stories, but each time slightly differently and with a different kind of nuance and meaning. Big problems if you accept claims at face value. Again, person says the divorce was terrible, but then you don't get the details. Again, assuming an understanding without additional information. In essence, it's a sort of empathic stance without knowing who you have empathy for, and therefore always false. Understanding these memories also can be derailed by failing to recognize that the events of the lives of the patient with schizophrenia are really not any different than our own. There may be more extreme examples of difficult things, but we can use our own autobiographical memories for a context for thinking about what it means when someone is going through something. If I sit with a patient and hear their stories, but I don't realize that they're fundamentally like me, I will not understand those stories. The fourth element is the psychological problem. And here the goal is to develop a greater awareness with the patient of themselves as confronted with dilemmas, challenges, and other kinds of distress. So a symptom isn't necessarily a problem. I hear a voice isn't necessarily a problem. I'm lonely because people have rejected me. I'm terrified because I hear a voice. I'm distracted and unable to connect to people because I hear a voice. Those are problems. And here it has to be unique, and it has to be with reference to what that human being is going through and the context of their life. And so with the first element, the patient is thinking about themselves as having an agenda. In the second element, they're thinking that their mind is meeting yours and they have a reaction. And the third, they're thinking about themselves in the course of their life. And then in this element, they're thinking about themselves as confronting something. All of these are metacognitive activities. And getting back to the metaphor of the physical therapist, in doing these, you're practicing with someone various acts, all of which end up bringing together how they think about themselves in the world. And they're training their own mind back on their mind. Just like people have multiple agendas, they may have multiple and contradictory problems. Their problem may be they depend on their wife and they hate their wife. Their problem may be that they can't live without drugs and they feel like the biggest loser on earth because all they've done is done drugs. And evidence that this has been successfully met in a session lies in joint reflection about potential and meaningful problems. It doesn't necessitate agreement about the correct or true problem, but reflection. So 5 people gathered around one person, all thinking about what that person's problem is. You're thinking about what my problem is. Each of you will have a somewhat different idea, and each may have some validity. But there isn't a single thing. Examples of psychological problems are being troubled by a history of sexual abuse, being uncertain about the origin of perceptions, anticipating failure or rejection, being consumed with feelings of mistrust, being lonely, confusion about what's going on in my head, wondering how other people see me, sitting on my porch looking out and wondering what's going on in the world. It makes no sense to me. I think we'll go next to the fifth item, or the fifth element of merit. And this is reflection upon interpersonal process. This element is as difficult and as simple as talking with someone about what's happening within the therapeutic relationship. And I would again remind you that these elements are not intended to be sequential. And so when and where you talk about this is a matter of discretion, timing, intuition, and thoughtfulness. And here the idea is that the patient becomes aware and thoughtful about the kind of relationship they're having with you. And so this is not merely the fact that they're noticing it's difficult to sit with you or they wish you wouldn't bring up a subject, but what is this relationship like? What's it like for them? Is it painful? Does it feel good? And it has to be sober reflection and also sensitive to the fact that it may involve feelings that a patient is loath to disclose, that they don't want to tell the therapist for fear it will drive the therapist away. This element requires therapists to create or seize upon opportunities for patients to reflect upon their own thinking about the therapy relationship in terms of what they experience at the moment and also are seeking to experience. And this requires that as therapists, you have to encourage patients to speak about difficult issues and welcome disclosures of negative feelings and positive feelings. As with the other elements, the goal is not a correct description of the relationship, but instead mutual reflection, thinking about what that relationship is. And it can be contradictory things. It can involve a range of emotions: jealousy, hatred, love, the full gauntlet of human experience, which one would expect would take place in intimate conversations. Things that get in the way of this are obviously being nervous about finding out how people think about you as a therapist. Having a negative reaction to someone telling you things about yourself that you don't think are true or that you feel you'd like to correct. The sixth element is the perception of change. And here the goal is to develop greater awareness of a patient's experience of progress or lack of progress. So whereas the last element required reflection about how does the patient experience the relationship, here, how do they experience the session? What's happening in it? Major barrier is, again, probably just assuming you know, that you assume this was a good session, or you assume that it was a bad session. But in each session, this element requires that you directly invite the patient to reflect upon what is changing and not changing, both within a session and between sessions. And this can include things that are expected, but also unexpected, and matters that are positive, negative, or both positive and negative. So it may be a patient will say, I'm surprised that we're doing this, but I'm surprised because it's good. Or I'm shocked that we didn't do that, and I feel that's been a major hindrance we didn't do it, or I'm glad we didn't do it. Certainly discovering that you have had an unexpected experience stimulates a person to reflect quite deeply about what's going on within the session. So these can be reflections about outcomes, progress over time, the impact of treatment upon life, and the management of distress, confusion, pain. The next element requires us to think back to the MASS-A, or the Metacognition Assessment Scale abbreviated. This in some ways is a superordinate element and refers to how, when you think with patients, are you thinking with them, joining them in a way that you're able to promote reflection at their maximal metacognitive capacity. In other words, when you stir someone to think about something, do you do so in a way that enables them to perform that metacognitive act? For example, if a patient is unable to name emotions but is aware of just different mental processes, do you intervene in a way such that you encourage them to think about mental processes without overtaxing them by asking them to do things they cannot do? Perhaps metaphorically, asking people to do things they cannot do is much like hitting the computer button over and over again, in which you put more and more information into the buffer and slow down the process. This element requires therapists to intuitively assess patients' metacognitive capacity within session, both with regard to self-reflectivity and reflection of others, and then to intervene at that level. So for example, if I assess that my patient is really operating at the fourth level of self-reflectivity, which is awareness of emotions, my intervention should function at that and not ask him or her to do more than they can, nor should I intervene at a lower level. So examples of interventions for patients who are at the second level of self-reflectivity would be just that there are thoughts in your head that are your own, and what those might specifically be. Interventions for patients at the third level of self-reflectivity would be you're having a dream, or you're having an emotion, or you had a memory. What was it like to have the memory? At the fourth level, there are reflections upon nuanced emotional states: jealousy, anger, sadness, surprise. At the fifth level, there are reflections or interventions that stimulate people to think about the extent to which they're uncertain about their own thoughts or how their thoughts change over time, and so on and so forth. More information about specific interventions for specific levels we have available for you. But the idea I'd like you to get right now is that part of merit is that when you think with people about themselves and others, you think with them at that level at which they're able to think. All patients are reflective, but at various levels of metacognition, people are more or less able to think in complex or integrated ways. So does the intervention match the patient's capacity? And if you have an intervention that doesn't match their capacity, do you then shift? One point that's worth thinking about is that metacognition may also change within session. And as a consequence, you may have to shift upwards or downwards as you think with the patient, such that as a patient is talking about himself, he may start out at relatively lower levels and build up to a complex understanding of a single event, hence being at level 7. And your intervention should follow him or her accordingly. Same thing with stimulation about others. We do not require that both self and other be stimulated within every session. And maybe there are some sessions where people think really lots about themselves or lots about other people. But this element requires that there be optimal stimulation for self or other within a given session. Ultimately, the therapist ensures that patients are stimulated to think about themselves and others, again, at that maximal capacity, with the thought that that then enables metacognitive growth. That repetitive practice of thinking at a level you're capable of enables you to get that level, essentially to master it and to move to the next level. I would also note that metacognitive capacity could change for a number of reasons within session, including progress in merit, but also the emergence of pain. And the ability to manage pain may also lead to changes in metacognition, as with the resolution of conflicts in a therapeutic relationship, and etc. And as you've seen from the graphs earlier, declines may follow improvements in metacognitive capacity. Offering interventions that exceed current abilities are likely to be frustrating, as we've talked about, and result in failure experiences, and possibly exacerbate symptoms. The final element of merit is this optimal stimulation of mastery. So whereas the 7th element called for the stimulation of reflections on self and others, every session should stimulate patients to think about mastery. And again, we're going to define mastery using the Metacognition Assessment Scale, abbreviated. And following the scale, mastery is defined as the ability to use metacognitive knowledge to respond to distress or challenge. And at issue then for merit is when I stimulate a patient to think about how they're responding to a psychological challenge, or even how they define or don't define a challenge, I need to stimulate them at the level of which they're capable. And again, a person who's barely able to do more than utterly avoid everything, my encouraging him or her to become more active and take behavioral steps may sidestep a necessary part of growth, or may miss the key point that this is the person who at best is only capable of avoidance right now. Those are the 8 elements of merit. Before we move on and talk a little bit more about the nuts and bolts of merit, I want to return and talk about the ethical principles that I mentioned at the beginning of this segment. And as you'll recollect, I mentioned beneficence and non-malfeasance. Psychologists strive to do no harm and seek to safeguard the welfare and rights of those with whom they interact professionally. This is a treatment that, above and beyond all else, seeks to do no harm. It seeks to think with people about what they want to do with their lives. It respects the progress they want to make. I think it is a treatment that offers the potential to interact without stigma and without marginalization. And as I had mentioned earlier on, many skills-focused therapies or treatments or interventions have the potential to be delivered with the patient being positioned as a passive person who is to follow advice given by a more powerful other. And that has the potential to harm. I think merit because it fundamentally pushes the patient's agenda to the front, because it is constantly interested in empowering patients, escapes, as much as I think you can, the potential to talk down to people or to keep them embedded in a marginalized position. There are certainly reflections by many scholars that much of this ability involves accepting the sick role as one's own occupation. This is a form of therapy that doesn't join with people in keeping up a sick role. It always treats people as able and capable of thought. The other ethical principle that I talked about is respect for people's rights and dignity, principle E. Psychologists respect the dignity and worth of all people and the rights of individuals to privacy, confidentiality, and self-determination. Psychologists try to eliminate the effect on their work of biases based on factors, and again, such as age, gender, disability, etc. And I think certainly merit, again, positions the patient primarily as an agent to decide what to do with his or her life, and ultimately is more empowering than anything else. Through the non-hierarchical relationship and by promoting reflectivity, patients are offered the optimal chance to make their own sense of things. And by really knowing people as individuals, there's deep, and there must be deep respect for the diverse qualities of their backgrounds and their own experiences, and ultimately assistance in their making meaning in their own lives, which is personally relevant and not prepackaged or tied to any particular culture. The hope is that this is a therapy that helps therapists avoid the pitfalls that others in more skills-focused approaches could fall into. To end this lecture, I want to talk about the nuts and the bolts of therapy. So we began with early experiences of mind, where it seemed like people developed in remarkable ways that I couldn't describe. We talked about Bloyler's idea that there's the collapse of these complex ideas of self and others. We've talked about how metacognition might measure that and in fact shows us some hint that that exists. We've now talked about a therapeutic approach and what it might have to have in it in general to target metacognition, and how that's a fundamentally ethical approach, or at least it's an approach which conforms with some of the core fundamental ethical principles of our field. It seems to me that it offers a reasonable explanation of the patients I saw in Ohio in the 1980s who moved from this state of confusion to having some core sense of who they are and to directing their life. But how do you do it? What does it look like? What happens when the door closes? How do you introduce it? In the last segment, I'm going to talk a little bit about how this therapy can begin, how long it often lasts, what the pitfalls are. So in the beginning sessions, what does the therapist do? What are you supposed to do? What is your role? How could you describe what you're going to do to a patient? And we've offered things as follows in those circumstances. My job is to listen as carefully as I can. I will try to understand exactly what you're telling me and asking me to do. I will think about the things you're facing with you. I'll try to share my thoughts honestly and clearly with you. Next question, what will we talk about? What do you talk about? Well, I'm not exactly sure what we'll discuss since I don't really know much about you or your life yet. But let's start. I'd like to get to know you to begin. Or I imagine we'll discuss some of the things you're facing in your life, parts of your past you're comfortable discussing, things you hope will happen in the future, things you feel good about, other things that are stressful or difficult for you. But in essence, what you'll do is you'll think with someone about their life and what they're facing and try to think with them about it. Patients have common reactions to this sort of introduction. They say, but I don't know what to say. You can say, that happens to almost everyone. It'll be okay if you're not sure what to say. We have plenty of time. Perhaps there's so many things to say it's hard to know where to begin. You don't have to feel like there's the spotlight on you. We can take our time. In these beginning sessions, patient also can say, but I don't really trust you. And sometimes that's okay. I mean, who should you trust right away anyway? We've said things like, it's okay, I don't trust people myself right away. What about the patient who begins therapy and has lots of negative symptoms, or is silent, or says they have no thoughts? Early on, what do you do when you sit with someone and they seem empty? Perhaps all they do is look at their hand, or they rock, or they say a few words. You can say things like, your mind is empty at the moment, and that's all you can tell. It's hard to have thoughts when you sit with me. Is it that you're having no thoughts, or are there thoughts that are difficult to express or you don't want to express? Is there something I can say that would help? Perhaps if we can talk today and a few other times, it'll help ideas to come to your mind. What about the patient, though, who doesn't think they have an illness? What does merit do if someone sits down with you and they say, I don't have schizophrenia, I don't need treatment, I don't even know why I'm here? Things you might say are such as, I guess we might talk about how it is that you're here. Did someone decide you should come here? How did that person decide it? I'm interested in how you see this, and I'm hoping you'll explain it to me, this process of how you ended up here. I imagine this is a tough position for you. Maybe we can still talk about something that would be helpful somehow to you. So we've talked some about beginning therapy, introducing this, what to do when people have negative symptoms or nothing, what to do when people say they aren't ill. But what about the patient who's so preoccupied with one particular belief that's all that he or she can talk about? What do you do then? How do you dialogue with that person? You can say things like, it seems it is important that we focus on this one subject today. How would you like me to respond to the subject? If we talk about this, perhaps eventually knowing my thoughts would be helpful. I feel uncomfortable interrupting you, but I want to know if you're curious about what I'm thinking as you're talking. What about the patient who repeatedly asks for affirmation of something? But I want you to fill in the blank. I need you to. You can say things like, I promise to tell you my opinion and want to, but there's still a lot I need to understand before I can have a real idea about this. What about the patient who shows up and is overly willing to please, who wants you to like them, who wants to tell you what you want to hear? You can say, I'm worried you're feeling some pressure to say the right thing or make sure that you're a good person. It's hard for me to know what you're thinking other than that it's so important that I recognize that you're a good person. It seems like the goal is for me to know that you're good, and the most important goal is for me to feel good. But I don't know what to think about you. What about the patient who comes to see you who's so disorganized, whose sentences don't fit together, who you can't understand what they mean, or their speech is full of so many obtuse abstractions you can't really grasp very much? You can say, you're telling me many different things. Seems like there's a lot for us to sort out. I'm getting the idea that there are many different things that might be difficult to understand. There are many, many points happening all at once. Sometimes patients come in and aren't very happy to see us and may in fact be sort of angry or hostile, upset. Certainly is not uncommon for people who are marginalized, facing considerable adversity, to be irritable or angry. What can you say? Well, one thing is, this seems like an uncomfortable spot for you. Perhaps it's hard to imagine our talking together could ever help. Or, I have the sense our conversation somehow feels insulting. I feel like no matter what I do, I'm insulting you. Or, I have the sense I'm not helping you very much. Is there anything I can do that could be helpful? We're talking about a therapy that is boundaried. It happens in an office, and it lasts for an agreed upon amount of time. Probably that amount of time will be different for different people. There may be some patients who want to begin meeting for a shorter period and then build up to longer periods. There may be people who want to come in twice a week, or those who at the most can see you every other week. But it's a therapy that's responsive to the needs, and we wouldn't prescribe a dosage for everyone, irrespective of their wishes. Because it's boundaried, like any boundaried therapy, it begins when the door closes. The conversation or the content shouldn't begin in the hall as you're walking towards the office, nor should it continue when you leave. This may be tricky and difficult for people who have a limited understanding of boundaries and who don't get social cues. So this may need to be explicitly discussed. There may need to be things said such as, "You're telling me important things, but I know we're in the hall. Let's wait till we're in the office." Or, "We have to stop now. I promise we'll see you next week, but there are things I need to do, so I'm going to let you go. I'll see you next week." It may be wise to not walk down the hall with the person after you've closed the door or the session is over, allowing for there to be an opportunity for continued conversation. It's also a therapy where ambivalence is to be expected. If you think about what schizophrenia means, the profound neurocognitive compromises, the symptoms, the metacognitive deficits we've described to you, relationships don't make sense. Attachments are often fraught with all sorts of anxiety and ambivalence. And that's likely to happen when someone comes to see us. Hence, it will not be uncommon for someone to sit down and be ambivalent about this kind of therapy, where we're going to think about your life and talk. A patient might, for example, note that they're not used to thinking with people or talking to them, or this is a strange idea. We've said things like, "I can see how our conversations may be different than others." Allowing other people to know your thoughts and then thinking with them, that might take some getting used to. Or it may take a while to get used to letting me know your thoughts. And again, this may feel strange. Patients might respond to ambivalence by saying they don't have anything to say, or there isn't anything anyone would ever want to say that they could tell you. An approach is to say, what you have to say is important to me. Your thoughts, your past, your future, they matter. I hope I'll be able to keep hearing about them and thinking with you. The thoughts and the lives of people are important, and affirming that violates no boundary and offers a foundation for reflections about things that someone might feel could be diminished or tarnished by the mind of another. What about the patient who says, though, that this is threatening and I'm not sure that I want anyone to know me? You can say, what you're saying is important, but it's you who decides what we talk about. You can put on the brakes at any point and I won't be upset. Is there something you'd like me to do when I listen to you or share my thoughts with you? Is there a way I can make this less difficult? A patient could note the emergence of traumatic pain or memories and not know what to do with them. Here you can say, I think some thoughts came up that you didn't expect. What should we do with them? You're having upsetting thoughts. I'm comfortable hearing more about them, but if you want to change the subject or drop these thoughts, that's okay. Just let me know. Again, I hope you continue to get the collaborative feel for this sort of conversation in the face of all these different problems. Again, what about that patient who's so abstract and obtuse, who's not sure they want to talk? Well, you can say, without talking about events in more detail, I can't imagine what you've experienced. I can't form a picture of your life if I don't know the details. I'm having a hard time forming an idea. Can you tell me about a place and a time where this happened? Or, I notice when we speak about specific times and places, it seems like that frustrates you, like I should know it already, or like it hurts for me to ask about this. The time frame of this therapy is likely to vary too from person to person. It may not be a brief therapy. In the therapies I've talked about with you already, we're talking about having spent several years with people. It may be that the type of brain injury that comes with schizophrenia, whether it's from social isolation, stigma, demoralization, actual neurodegeneration, is so great that a lengthy period of time is needed for rehabilitation. If we think about someone with a severe head injury, a terribly severe head injury, a period of rehabilitation over years would not be unexpected. I think there are things to keep in mind, though, as you do this work as well. And there are other considerations that I wouldn't want to leave without mentioning. Traumatic memories may emerge. People may remember things in ways that they didn't expect and that hurt. Giving up the sick role, feeling like a healthy person, may be more difficult than expected. People may have become quite comfortable in a role in which everything's predictable. While there are many downsides to a sick role, it is at least a role, and it's a way to negotiate relationships and know how to present yourself. And it may be difficult to figure out what comes next when that's lost. There may be ceiling effects. It's unknown whether we're talking about a therapy that leads people to recoup premorbid levels or just really encounter better abilities. Substance use and suicidality have to be monitored continuously and taken seriously at every juncture, as you would in any case. The therapeutic relationship, whether using the words transference and countertransference or others, can be unexpectedly powerful. If you think about someone who's been marginalized and cut off from the world, they may find it quite enormously evocative. People who have been cut off from the world may find it quite evocative to relate to a therapist. It may at times be tremendously powerful for the therapist as well. Knowing someone who is profoundly powerless, empty, and lost can be enormously distressing and cause therapist anxiety. And supervision is needed. Regular supervision is needed for this type of work, as well as consultation. Hostility seems in our work to be a common theme that comes up in this type of therapy. And it may have an essential place and not be a sign that things are going wrong. Again, if you go back to your favorite TV show or movie portrayal of therapists, usually therapists, there's a hostile moment, but it isn't really a sort of an angry set of exchanges that go on. But it may be, again, that for people who are marginalized, powerless in the world, stigmatized, frightened, upset, there's tons of affect pent up and rage that needs to be experienced and dealt with. And self-stigma has to be continuously monitored by both for the patient, and we have to monitor our own stigma as well. In terms of the actual course, it's likely therapists will be more active in the early sessions. And it's likely that as therapy moves on, later sessions will involve more of a focus on the relationship and less concern with identifying psychological problems. Breaks in the therapy are not unexpected and not necessarily undesirable. It may be that people will make gains that they're comfortable with and take time away. Our experience has certainly been that there are many cases in which there are substantial breaks followed by substantial re-engagement and gain. And finally, termination. This is not intended to be a life therapy. We believe this is a therapy which can end and end meaningfully following any core set of reasonable understandings of the termination process. terms of the current status of research, I'll tell you there's an ongoing trial at the moment in the Netherlands. Our colleagues we mentioned earlier are pursuing that. There are additionally other small open trials that are ongoing, some of which have been published, providing at least evidence that this is a therapy that is acceptable and not associated with negative outcomes. For the majority of patients, it appears to be associated with some reasonable amount of clinical gain, but more research is needed, and certainly comparisons with other therapy is warranted. As a summary, I'll tell you that when I think back to these early years in Canton, Ohio, Alliance, Ohio, as a young therapist, someone in his mid-20s, I remember encountering a group of people whose lives appeared to be sort of clothed in a fog, who appeared to live in a fragmented state with little sense of their history, and somehow or another talking to them hour after hour over a period of years, that seemed to remit, the fog remitted, and people seemed to emerge in a fuller, richer sense. I think the metacognitive framework we've talked about provides a way to think about that, makes it make sense to me in my own mind. But I hope it's moved much more, I hope this has moved well beyond an explanation, though, for something that happened 30 years ago. The hope is that merit represents a set of principles that can be applied by trained therapists from any number of legitimate practices and schools. The hope is that with training and supervision and consultation, people can master these principles and use them in a creative way that stimulates their own practice, ultimately leading to recovery-based outcomes. We hope that at the heart of this is a therapy that's consistent with the core ethical principles we've talked about, that there's an ultimate respect for dignity, that there's a movement away from elements of treatment that can institutionalize or demoralize people, and in the end, create the kinds of, assist patients with severe and persistent mental illnesses like schizophrenia to create the kind of lives that they need and want.
Can you explain a little bit more about integration? On the one hand, it seems like a very complex process, yet on the other, it's something we do all the time.
Sure, indeed, the core of merit is promoting the capacity to integrate information. I think oftentimes when people think about this, and of course we've referred to it as metacognition throughout, when people think about metacognition, they think of an activity that's performed late at night or in a private place. But really it's ongoing every day and is essential for human functioning. But it's also incredibly complex. And so maybe to illustrate, we can just talk about what happens when you're forming an idea of someone else. Imagine you meet someone for the first time. Say it's at a social gathering. Immediately there are feelings in your body when you see this person. You also notice things about them. For example, you notice what expression they have on their face in that moment. You also notice how they're dressed, how they move. You notice the qualities of their speech. So in addition to things they're saying, how quickly do they talk? What sort of language do they use? So all this is going into an immediate experience of meeting another person. But also you know their personal characteristics. You notice how other people react to them. There's how that person treats you. There are the things that they believe and value. There's a knowledge of how people have acted in similar situations when you've met them in other places. And somehow this and many, many, many other things have to all be fit together into forming a picture of who that person is. And that's what we mean by integration. And it's automatic. And if that's not complex enough, of course, you meet that person at multiple other times. Perhaps you run into them at the grocery store. You continue to meet them at social gatherings. And every time you do the same thing, except for now you have to combine all of those different experiences into a single sense of who that other person is. And that tells you how that person is different ultimately than other people. So imagine for a moment if you couldn't do this. Everyone ultimately would look the same. Or at the best, they would be a collection of things you didn't know how to fit together. And meeting them each time, you would have little sense of how in the world you should interact with them and get along with them. So this sense of the other person, again, is not just an intellectual activity. It guides how you behave with them. It tells you what you should count on them for. So this idea is also not this is a good or bad person, but this is a person who's useful in a certain circumstance or in a certain context. So the ideas you form of one person might tell you there's certain things you should turn to them for, whereas other things are not likely to be helpful. The interpersonal world would be confusing and you wouldn't know who you could turn to. The same thing is true if we think about integration for sense of self. So this is also not something you just perceive or a single thing. But if you think of who you are in any one particular moment, they're the feelings in your body, perhaps tense, perhaps relaxed. There's also the context in which you're observing yourself or wondering what's happening with yourself. If you think about who you are at a moment, there are all the different people who you're attached to in the world. They're your own personal characteristics. There's your sense of who you are in terms of what you hope for, what you've accomplished. There's a sense of how others treat you, about how others see what's happening. There's your own expectations, values, the things you've accomplished, failed. Again, it's a gigantic number of things that's impossible to detail, which all have to be fit together into a picture of who you are at the moment. And as in the case of thinking about other people, you do this repeatedly over time. And again, not just late at night, but you do it when you're in a restaurant and you have a contentious exchange with a waiter. You do it at work when you're planning out what next step to take. Do it in the morning when you're driving to work. And all these different views you have of yourself have to be fit together with previous views into a larger view of who you are. So synthesis, therefore, is a big deal in regular life. It's a core for adaptation. It's how you know how to respond to things, how you know who to trust. Of course, your integrated sense of who you are and who other people are influence each other. How I understand myself has to do with how I understand other people. My sense of who you are determines how I respond to you, ultimately all leading to a larger worldview. An ongoing automatic process, but one that involves reflection that's essential to human adaptation and rests at the core of what merit seeks to accomplish.
So I wonder if now we can talk a little bit about some of the practical matters of practicing merit as a model of psychotherapy. One thing we'd like to hear a little bit more about is how do sessions in merit usually start?
So every session, of course, begins differently, as every unique patient is their own person. Some people begin in the middle of a crisis. Some people begin saying they don't know what to say. Some people come in with tons of things that are on their minds. So the session usually begins with the therapist paying particular attention to what the patient is saying to them, what are the exact words, and looking for clues about the meaning of what's about to unfold. So if the meaning of all human speech is contextual, meaning the words I use mean what they mean because of what's around them, the therapist pays attention to what the person is saying. And then from the get-go is interested in trying to figure out what their agenda is. So the patient sits down and the question is, what is the mission? And the therapist doesn't assume ahead of time they know. They should have some recent and good working sense of what other missions or agendas have been, but no assumption of what it is. And then as the speech acts emerge, the idea is to see if you can determine with the person what sort of wish is going on behind it. So let's assume that patients do not come in and say, hello, my agenda is as follows. Hello, today my goals are as follows. For example, they might say, I hate my partner. They're doing all these horrible things. Can you imagine? Why would my partner be such a bad person? So that's the way a session may begin. Alternatively, the patient may say something different. They may say, I'm interested in talking to you today, but I gotta say, I'm starting to have doubts about how competent or able you are to help me. Another patient could say, gee, I'd like to start, but I'd like to ask you whether or not you've been filming me in my home or are following me after work. Are you talking to people in the FBI about me? Another patient might say, my goodness, am I upset today? Holy mackerel, am I angry about the parking situation outside my apartment, and then I drove here. Drivers were so horrible, and I almost wrecked. Sessions can begin this way. So what we're interested in is what's the agenda or the mission behind each of these things. So think about the patient who tells us, don't you hate my partner? He or she is so obnoxious. Perhaps the agenda is to avoid feeling guilty, to ensure that you, the therapist, will agree with them that the partner is awful and then they don't have to feel bad about a fight. Consider the person who says to you, my goodness, you don't know much, I don't think you're very competent at all. Perhaps their agenda is to feel important or to be important. The person who asks, are you watching me, following me, etc., their agenda may be to establish that they're safe and to feel safe. And the person who's overwhelmed with traffic might be asking you to please help me feel less anxious. So sessions begin with therapists considering and thinking about the very first things patients say and seeking for the agenda. If merit is indeed going to help people to think about their thinking and to recognize what's going on in their minds, they have to see themselves from the beginning as someone who is an active agent, who has mental activities that can be thought about and understood.
How do you deal with the crises that inevitably crop up and still maintain a merit framework?
Certainly, psychosis is a profoundly disabling and disturbing condition for human beings, and crises are to be expected. Certainly, if issues of dangerousness emerge, they have to be taken seriously, and you should follow all standard clinical practices and ensure that people are safe and are not in a position where they are at risk to harm themselves or other people. That said, a crisis should be considered as any number of things, all again driven by a patient agenda. So a patient who comes in and says, I'm having a crisis with my neighbor, what's the agenda behind that? Is it to help me to be calmer and not to be so angry at my neighbor? The agenda could be that I wish to distract you from the fact that I've been doing drugs or doing other unwise things during the week, and I want to point your attention somewhere else. That is a crisis that could signal that I'm about to use drugs or alcohol, and I'm hoping you'll help me to avoid it. So when faced with a crisis, issues of dangerousness have to be addressed first, always. But then comes the issue of what is the intent behind this? What's the agenda behind the presentation of the crisis? With many multiple possibilities, including, please help me to be calm, please reassure me, I'm seeking reassurance, I'm seeking safety, or I'm again seeking to distract you by focusing your mind elsewhere. So the merit therapist attends to the crisis, does not ignore the realities of the psychosocial surroundings of the patient. The therapist is always thinking of the patient as an agentic being and assisting them to think in the same way about that. I think what merit doesn't want to do is to go into a mode every time there's a crisis and solve the problem for the patient and then get back to the issues of metacognition and therapy. Dealing with crises should be considered as part of the process of merit, and all of the elements apply, including looking for narrative episodes, looking for the psychological problem, stirring the person to think, as is the last element of merit, about how they're using knowledge of themselves to deal with the crisis.
So, how do you manage the end of a treatment session?
So sessions end as you would expect. They should end at a certain time. It should always be a moment of reflection on what the session has been like. So in the fifth element of merit, where you ask the person to think about how things have gone during the session and how these events in the session have changed the activities in their own mind. So it's a chance for the person to integrate and pull together what's been spoken about and how it's affected or impacted them. And as we've talked about with the fifth element, this should include thinking about whether what happened was expected or surprising. Independent of that, what happened was positive or negative. Independent of that, to what do they attribute these changes? What are they about? Some patients may need a cue that the session will be ending in 5 or 10 minutes. There may be resistance to ending on time. The person may have experienced that this is a sort of bond that they don't experience outside of the session, and they may find it disorganizing as they prepare to end. It is not uncommon for patients to end sessions with odd or unusual comments, which seem to be a way to kind of destroy the connection with the therapist so as to make the pain of leaving the session less poignant. It's important to discuss what the end of the session is like for people outside of what happened during the session. In other words, does it feel good to be ending? Is it disorganizing to be ending? Is it difficult to be ending? All of these, again, are opportunities for reflection and for the patient to think about what is happening in his or her mind.
So, how is recovery understood within merit?
So merit at its core is about assisting people to form the kinds of integrated ideas about oneself and others needed to respond to the challenges of life and to recover from severe and persistent mental illness. More important than any other characteristic is that the person themselves has to direct their own recovery. That recovery doesn't proceed because of a more powerful other who tells them what to do or solves their problems for them. So merit at its core is interested in assisting people to figure out how to direct their own recovery, to decide on their own what the challenges of mental illness mean to them, to decide how to create an understanding of that that can be shared with others, and as we've talked about, some that also isn't infected by stigma. Part of recovery involves having hope, it involves having some sense of self-direction, and ultimately merit hopes to assist people to have a view of the world which enables them to be reasonably hopeful and to hope for things that are within the scope of possibility given the limits of mental illness. Recovery involves the ability to make your own choices about how to manage symptoms, how to respond to previous experiences, including issues of loss and embarrassment. Common experience for many people with serious and persistent mental illness is that they feel deeply embarrassed or in fact even traumatized by experiences of their illness. And a common experience in merit is that people think about earlier experiences with mental illness, ones which previously felt incomprehensible or ones which permanently tainted their identity. And they come to make new sense of those experiences such that they can see themselves as, quote, normal people, perhaps who've had abnormal experiences, but to see themselves as the same as everyone else, and therefore able to live with experiences which previously had been painful or difficult. In this sense, merit seeks to help people recapture a core sense of personal dignity. One of the most difficult things for many therapists as they begin to learn the merit method is they're used to looking at singular discrete problems and then thinking about solutions for those problems. Merit, on the other hand, really demands that the therapist keep his or her eye on larger processes, on these disturbances in integration that we've been talking about. So to provide an illustration, what you'll see here is a green circle with 3 discrete problems that a therapist might find in a patient they're working with. They might encounter a patient who has self-stigma, who doubts themselves, thinks about themselves as dangerous or incompetent. The same patient, they could experience helplessness or low self-esteem. They might, as a result, not want to really adhere to treatment and withdraw. So those are 3 different problems that a therapist could find, and indeed these are legitimate and serious problems. But there's often more to it, and what you'll see now is that another therapist, or even the very same therapist, could see that there are additional problems. The patient has a delusional belief or has the experience of hallucinations, or that person experiences thought disorder or avolition and really struggles to form a coherent picture of action that they can follow. Of course, it gets even more complicated in real life because the patient may have poor social skills or limited work skills. They may really have struggled in terms of resiliency for much of their life or come from a background where there's a lot of conflict. So what you can see here are at least 12 different discrete and very real problems that are interfering with the patient's life. And in usual clinical context, the therapist goes about trying to find a solution for each of these, or at least address meaningful groups of them. But Meredith wants the therapist to do something different. We want the therapist to see that these are all taking place in the mind of someone who's actively making sense of information, or at least struggling to integrate all the bits and pieces of daily life and make sense of it. And what Meredith then wants to do is, by addressing the field of integration, or people's abilities to form integrated ideas, to help them develop the capacities on their own to make sense of these things and make sense with therapists in order to ultimately resolve these issues.
What are the subjective experiences of therapists who are learning to do merit?
So like we first talked about, there's this process of looking beyond the specific problems or difficulties and seeing the person as a whole person and also as someone who's persistently and constantly making meaning. And this often leads therapists to realize there's much about the patient they didn't know. And as they get to know them, realize all sorts of facets of that person that previously were invisible. And that they've been making all sorts of assumptions about who that person is that have guided them to form an image of the patient which doesn't match who that person really is. A common experience also is that many speech acts or things that patients say which previously seemed meaningless or incoherent have rich and poignant meaning. In other words, things that were viewed as merely fluff or not relevant speech take on greater meaning and in fact give a bigger meaning to the larger process. Many therapists also end up feeling deeply moved by the emergence of meaning and coherence. They have the experience of meeting someone who makes little to no sense, or perhaps is empty or focused on one theme, and that person begins to make their own sense of the world, and they begin to emerge as a real, live human being with full dimension and depth. The subjective experience also depends on people's previous training and their own theoretical biases. And so, for example, a common experience for a cognitive behavior therapist is that they're quite familiar with trying to know what's happened in the minds of patients. But the idea of focusing on the complexity with which that material is integrated may seem new and foreign, and by a matter of habit they may default to trying to characterize what the person believes rather than seeing the qualities that underlie those beliefs. A common experience for humanistic therapists is they feel well equipped to offer warmth and acceptance. They often are surprised by how that warmth and acceptance is experienced by the patient as threatening, and the patient may therefore rebuff and avoid them. They may need to adjust their style, be more neutral, and in fact, be more tolerant of moments where the patient doesn't want warmth or acceptance. Psychodynamic therapists come in well versed in thinking about conflicts and how pain tumbles forth into disordered behavior. But these therapists, by contrast, may need some time to develop the ability to think about real-world solutions and to think about pressing people to focus on how they respond to problems and how they might respond differently. One form of psychodynamic treatment closely aligned with merit is mentalization-based therapy. One core difference from mentalization therapy is that merit does not understand metacognitive disturbances as stemming solely from disturbances in attachment. In fact, merit views disturbances in attachment as potentially functionally autonomous from metacognitive disturbances, such that enhancing metacognition might assist patients to deal with disturbances in attachment. And a common experience for mentalization-based therapists is a sort of surprise at the level at which patients are able to use ideas about themselves and others to adjust how they relate to people, and not only the other way around.